All right, welcome back. I'm Dr. Stokes with Bread and Butter Primary Care, and today's talk is about treatment of depression. So, this is entitled Initial Treatment of Depression, How to Choose Your First SSRI. And so, the number of medications, treatments that are available for depression are many. There's dozens and dozens of medications that can help with treatment of these conditions. And so it can be daunting, especially when you first are starting to deal with these problems when you first start your job or in your preceptorships or whatever it may be, in knowing, well, how do I know? Well, how do I know which medicine is right for which patient? And so we're going to talk a little bit about that from a couple different perspectives, and hopefully by the end of this little talk, you'll feel much more comfortable picking an SSRI, picking that initial treatment, and going for it. Before we talk about the medications, which I'm going to spend most of this lecture talking about, don't forget the treatment plan as far as non-medication management when you're dealing with people who have any sort of mental health disorder, and especially major depressive disorder. Counseling is absolutely essential to help these patients do that. Talking about exercise and physical health and those types of things can also be very, very helpful. And we'll probably have another video specifically talking about the best non-medication things that might be helpful. This video, we're really going to focus on you're in with a patient, they are presenting with a major depressive disorder, the diagnosis has been made, and they would like medication. They have decided they would like to try medication, see what would help. How do you know? How do you choose? So the first thing I'll tell you, and this is what I tell my students when they first come and rotate with me, is don't worry too much about it on the one hand, because after several years of experience, and depression is something in bread and butter primary care that you see all the time, these medications are very particular in that they'll work really well in one person, and a different medicine will work well in a different person. And the actual ability to know a person well enough to make that decision is pretty low. I think psychiatrists who do this all the time, they have a little bit more knowledge of the different receptors that the different medications bind to, which hormones, norepinephrine, epi, and serotonin and dopamine, do they tend to increase, and if the patient has this symptom or that symptom, they might choose one that has more dopamine because of this, or more epinephrine release, or that type of stuff. And so when you do your psych rotations, you might come across that. As far as in primary care, that is, at least in my opinion, kind of beyond what you generally will know about these medications. And so on the one hand, there's a few things that help me decide which medication to start with. On the other, sometimes I'm convinced that you could just write all these medications down on paper, put them in a hat, and draw one out and try that one. And you may have just as much success picking the right one. So I always tell my students that, and I'm telling that in this video because worst case scenario, in most cases you can't necessarily pick wrong, because it's very, very hard to know which serotonin reuptake inhibitor is going to help one person and which is going to help another. So that being said, if you have no reason to pick any of the others, then you can just pick any of them. There's five, as far as the old generic SSRIs, there's kind of five main ones that are in my first group. Prozac, which is fluoxetine; sertraline, which is Zoloft; Paxil, which is paroxetine; Lexapro, which is escitalopram; and Celexa, which is citalopram. So those are the five kind of core SSRIs. If they've never been treated, there's no reason to pick anything else, then I'll pick one of those five. The only things that push me towards another one, there's a few scenarios. Adolescence. I almost always start Prozac in adolescence. That's because of the half-life of Prozac is the longest of the SSRIs. It has the slowest, easiest onset, and also the slowest, easiest dropping off. So discontinuation syndrome is something you have to be worried about. If people are on a steady level of serotonin reuptake inhibitor and they suddenly stop and those levels drop, then it can cause discontinuation syndrome. It's not really withdrawal, but it makes them feel very miserable and sick and not well. Prozac has the least amount of that problem because of the long half-life. So adolescents are notorious for taking their medicine sometimes and not taking it other times, stopping it without warning and that type of stuff. It's also kind of the oldest SSRI. It has the most information, and so unless there's another reason, I tend to use Prozac or fluoxetine in my adolescent patients. So that's one that will push me one way or another. Paroxetine or Paxil, I have found, and in some of the reading that I've done, seems to be more sedating and more calming. So generally, if it's a angry, irritable, prone to violence male or female, but usually the aggressive patients are more in the males, then I tend to go with Paxil first. Now, again, that might not be right. You might have an aggressive, angry, irritable symptom type of individual, and Paxil doesn't work, and then you try Celexa and it works really well. And so, like I said, there's not necessarily a reason to pick one over the other, but I tend to find that Paxil tends to be calming and sedating and a little bit more than the others. And then sertraline or Zoloft is the one I use in pregnancy. So I'll probably have another separate video on the treatment of depression in pregnancy, but of the antidepressants that are available, sertraline seems to have the best evidence for safety as far as SSRIs. And so Prozac for adolescents, sertraline for pregnancy, Paxil for irritability and angriness. Other than those three reasons, you really can kind of pick whatever you want. Previous history is a huge thing, so if they're like, hey, I've been on Zoloft and it worked, then go with that. I mean, because some of the work's already been done. Because one of the things that is sometimes frustrating when you start SSRIs in patients is you start it, it takes a month to work, and if it doesn't work, then you've spent a whole month just to find out it didn't work. And then you tell them to take a different one in another month and it doesn't work. And you're telling them to try that third one, and they're like, hey, these medicines don't work for me. But I have had that third or fourth choice work. And there'll be another video about when to stop trying the plain SSRIs and move to a different class as well. And so if there's a previous history where they know something did or didn't work, then go with that. If there's a family history, if they say, well, my brother or my sister is on Prozac and they do really well on it, could I try that? That's another reason to pick one. So personal history is a reason to pick one, family history is a reason to pick one, or patient preference. If patient's like, look, I've read about Lexapro or I've read about this, that's what I want, then that's another reason to pick it. So that's the kind of the lowdown on that. And so in review, if the patient has a preference, if they have a personal history, or if there's a family history, that will likely guide your choice. Prozac for adolescents, Zoloft for pregnancy, and Paxil or paroxetine for anger and irritability. Otherwise, and even in those circumstances, you can pretty much pick whatever you want. A few interesting tidbits about some of the particular SSRIs, two in particular, Celexa and Lexapro. Celexa is citalopram. Lexapro is S-citalopram. If you harken back to biochemistry days, you'll remember that biochemicals oftentimes have an S and R form, which are like mirror images of one another. And so Celexa, citalopram, and Lexapro, S-citalopram, are in a lot of ways the same medication. Lexapro is just the S-only form, whereas Celexa has a mix. And so what that means is that Lexapro, in a way, is just purified Celexa or citalopram. So the maximum dose of citalopram is 40 milligrams. If you go higher than that, you're likely to run into side effects and problems. The maximum dose of Lexapro, of S-citalopram, is 20 milligrams, so it's actually lower. But a good rule of thumb, and I learned this both from some reading that I did as well as some rotations with psychiatrists in residency, is you can consider Lexapro to be 4 times stronger than Celexa. And so 40 milligrams, I'm sorry, I think I said that wrong, twice as strong. So, no, I was right. So I was thinking the other direction. So yeah, so 4 times stronger. So if you have 5 milligrams of Lexapro, that is similar to 20 milligrams of Celexa. And so maximum dose of Celexa is 40. Maximum dose of Lexapro is 20, but 20 times 4, so Lexapro 20 is kind of like Celexa 80. And so that's helpful just if you're dealing with that medicine in particular. If someone's on Celexa and you've got them at 40 milligrams and they come back and they say this really helps, but it's not strong enough, I need a higher dose. It's above maximum to go above, but you could switch to Lexapro 20 and effectively be increasing their dose of Celexa. So Celexa and Lexapro are kind of interesting in that sense, so I wanted to bring that up as well as far as when you're choosing which SSRI to start in a patient to start their treatment. I hope that's helpful information for you. Again, any questions or comments I'd love to hear down below in the comments, and I hope you guys have a great rest of your day.